So what is the first line treatment for type 2 diabetes? Well, it is lifestyle, lifestyle, lifestyle. And this does not mean a cursory eat less and move more. We need to set specific goals with our patients and counsel them on specific ways that they can optimize their lifestyle to improve their insulin sensitivity. We use SMART goals. These are specific, measurable, attainable, realistic, and time-bound goals. We use these goals like a prescription. Instead of telling a patient to move more, we ask the patient, what type of exercise would you like to do? If they would like to walk more, we ask them, okay, how much will you walk? When, where, with whom? What obstacles will you face? How will you overcome those barriers? And how confident do you feel that you can achieve this goal in X amount of time? If their confidence level is a 2, we have to revisit the goal and recreate a goal that they feel confident they can achieve in a certain time frame. We shoot for a confidence level of 7 or above, 0 being not confident at all, and 10 being highly confident that they can achieve a goal. Once the patient achieves their first goal, they're more motivated to move on to their next goal. These SMART goals are a great tool that helps our patients make progress, track progress, and feel good about their progress. Patients want to improve their lifestyle. We need to choose therapeutic options with pharmacology that augment our patients' efforts at lifestyle. First, let's start with metformin. Metformin is still a potential first-line therapy for type 2 diabetes when moving into medications. Metformin is a great medication. It lowers A1C on average by 1.5%, and it does not cause hypoglycemia. It is relatively weight neutral for most patients, but some patients do lose weight on it. However, there are other options that can be used as first-line agents, like GLP-1 receptor agonists and SGLT2 inhibitors. These medications do promote weight loss and have cardiovascular and renal benefits. They should be considered early in patients with those comorbidities. Metformin should be dosed properly to get the best compliance. Metformin should be prescribed as metformin extended release because that decreases side effects. The most common side effects from metformin are GI side effects like bloating. Now, we start metformin low at metformin ER 500 milligrams PO daily and increase by 500 milligrams per week until they reach a max dose of 1,000 milligrams PO BID. The reason that we go up slowly is that this increases the body's tolerance to the medication. So for example, you would start a patient on metformin ER 500 milligrams with dinner for a week. Then the next week, if they're doing fine, increase it to 500 milligrams PO BID with breakfast and dinner. Then you could increase to 500 milligrams in the morning and 1,000 at night, and then the next week increase to 1,000 milligrams twice a day. This is really important because when we start a patient on 1,000 milligrams PO BID out the gate, they are much more likely to have side effects from the medication and thus discontinue it. And this takes a very potent and inexpensive medication off of the table for a patient who may have had an opportunity to use it if it was prescribed in a way that improved their tolerance. GLP-1 receptor agonists are great medications for patients with type 2 diabetes. They come by the names liraglutide, semaglutide, and dulaglutide. These medications work on the pancreas and tell the pancreas to secrete more insulin when the blood sugar is high. But they don't act on the pancreas to secrete more insulin when the blood sugar is normal or low. Thus, they improve hyperglycemia but don't cause hypoglycemia. They also have cardiovascular and renal benefits as well as impressive weight loss benefits. They cause weight loss by reducing appetite. They work on the GI tract to reduce motility, thus decreasing appetite, and they also work on brain receptors to decrease appetite. These medications alone cause A1C reduction of 1.5%, but the A1C reduction can be much more with weight loss that comes with these medications. I have seen many patients come off insulin completely on these medications, which reduces their injection burden from 4 times a day to once a week. This is a huge quality of life benefit for patients. These medications do have some side effects. The most common side effect is nausea, which typically resolves in 3 to 4 weeks. A rare adverse effect of these medications can be pancreatitis. It was seen in less than 1% of patients on these medications, and that's what I see clinically. Another potential adverse effect of this medication was only seen in rodents, and that was increase in medullary thyroid cancer. The significance has not been found in humans. It's important to inform your patients about this because there is an FDA black box warning on these medications, and if you don't warn your patients and educate them, they may fail to start the medication if they read it on the internet after it's been prescribed. These are great medications for patients with diabetes and should be considered. The next class of medications that we have are SGLT2 inhibitors. They come by the names of empagliflozin, dapagliflozin, and canagliflozin. These medications enable patients to excrete blood sugar when it is in excess, but do not cause the blood sugar to be lost when the sugar is normal or low. Thus, they don't cause hypoglycemia. They also do facilitate a bit of weight loss. These medications have demonstrated cardiovascular benefits, especially in the setting of heart failure, and renal benefits. So they should be considered in patients with those comorbidities. They do cause increased urination. The most common side effects of these medications that can cause patients to stop the medications are yeast infections and urinary tract infections. These do happen on occasion, so we need to screen patients before starting the medications and stop if we do have some of these side effects. A rare but frightening adverse effect of these medications is euglycemic DKA that can land some patients in the hospital, so patients do need to be monitored for those. These medications do have potential for other rare adverse effects like Fournier's gangrene and amputations with canagliflozin. So patients do need to be screened and monitored for these potential effects. SGLT2 inhibitors and GLP-1 receptor agonists are still expensive medications, even though they've been around for a decade. However, many insurance carriers do cover these medications, both federally funded, state-funded, and commercial insurance plans. It is always worth checking with the patient's insurance company and writing the prescription to see if these medications are covered, because they are very good and superior to some of the older medications that we have, and you may be surprised about their coverage. There are also savings cards online, and pharmaceutical representatives can help facilitate getting these prescriptions to your patients. Sulfonylureas are an older class of medication that are effective at lowering blood sugar. However, they also cause weight gain and they cause hypoglycemia. So these medications should only be selected in rare patients as first or second line. When cost is an issue, these may be good options. These are especially dangerous in patients particularly sensitive to hypoglycemia, like patients with cardiovascular disease and elderly patients. Definitely use these medications with caution and consider other agents. Next, TZDs like rosiglitazone and pioglitazone. These medications do improve insulin resistance and fatty liver. However, they also are associated weight gain and have a black box warning for patients with heart failure. These are more affordable and may be considered in patients where cost is an issue. Next, we have DPP-4 inhibitors like linagliptin, sitagliptin, and saxagliptin. These are more expensive medications that work similarly to GLP-1 receptor agonists. However, they do not have the weight loss benefits, cardiovascular benefits, or renal benefits. They are not as potent as GLP-1 receptor agonists either. They do have a very good side effect profile, so should be used in patients where other medications were not tolerated or elderly patients who need small adjustments to their A1C.
The first-line treatment for diabetes is often overlooked. It is lifestyle, lifestyle, lifestyle. This is not a cursory eat less, move more. It is not that easy or obvious. Counsel your patients specifically on a dietary pattern that maximizes insulin sensitivity, like we discussed before. Supply them with resources. Set specific goals. We use SMART goals: specific, measurable, attainable, realistic, and time-bound. We revisit these goals on each visit and set new ones when they are not working or when they have been achieved. This sets patients on a path of progress, which is far better than the all-or-nothing mentality that comes with seeking overnight perfection. So, in review, metformin is still a great and effective medication for many patients. GLP-1 receptor agonists and SGLT2 inhibitors may also be good first-line medications for patients with comorbidities such as overweight, obesity, cardiovascular disease, and/or kidney disease. Metformin is still a great medication, and we need to keep it on the table for as many patients as we can because it is inexpensive and effective. In order to keep it on the table, we need to ensure that we're doing everything that we can to minimize side effects from this medication. To do so, we prescribe metformin ER, extended release, 500 milligrams. We start with 500 milligrams PO with dinner for a week. If that is well tolerated, we increase to 500 milligrams PO BID with breakfast and dinner for another week. If that's well tolerated, we can increase to 500 milligrams PO QAM with breakfast and 1,000 milligrams PO QPM with dinner for another week. And if that's well tolerated, we can increase to the max dose of 1,000 milligrams PO BID with breakfast and dinner. It should be noted that metformin does not cause kidney damage in normally functioning kidneys. Metformin is a very effective medication, and diabetes does cause diabetic nephropathy and kidney damage, and metformin can be used to actually prevent diabetic kidney disease. We should use metformin with caution in patients with already reduced kidney function. If a patient has an eGFR of 30 to 45, do not initiate metformin if they are not taking it yet, and if they are already taking it, their max dose should be 500 milligrams PO BID. If eGFR is less than 30, then metformin is contraindicated. As we discussed, GLP-1 receptor agonists are wonderful medications for type 2 diabetes. Let's review how they work. GLP-1 is an incretin hormone secreted from the intestine, and these medications augment GLP-1's effects. They cause increased insulin in the setting of high sugar, but do not cause hypoglycemia. They work most postprandially. They also reduce appetite and improve satiety by slowing GI motility and by working on brain receptors, thereby facilitating weight loss. Nausea is by far the most common side effect of GLP-1 receptor agonists. Some patients also experience constipation and acid reflux. These GI side effects typically resolve after 3 to 4 weeks of starting the medications. Most patients find these tolerable and do not have to discontinue the medications because of these side effects. There are some rare but potentially dangerous adverse effects from GLP-1 receptor agonists that we should discuss with patients. Pancreatitis was seen in less than 1% of patients in studies, and that's what I see clinically as well. The causation is still uncertain. There's also a black box warning for medullary thyroid cancer that was seen in rodents on GLP-1 receptor agonists. It is really important to discuss this with your patients to inform them before they go look it up on the internet and decline to take the medication. The significance is not known in humans, and medullary thyroid cancer due to GLP-1 receptor agonists has not been reported in humans. Prescribing GLP-1 receptor agonists can be intimidating at first, so let's review it. With GLP-1 receptor agonists, we like to start low to enable the patient's body to acclimate to the medication and to reduce side effects. The first one we'll discuss is liraglutide. This is the once daily GLP-1 receptor agonist. We start at 0.6 milligrams sub-Q daily for 7 days, and if that is well tolerated, we increase to 1.2 milligrams sub-Q daily for 7 days, and if that's well tolerated, we increase to 1.8 milligrams sub-Q daily, which is the max dose of this particular GLP-1 receptor agonist for diabetes. Next, we have semaglutide. We start at 0.25 milligrams sub-Q weekly for 4 weeks, and if that's well tolerated, we increase to 0.5 milligrams sub-Q weekly for 2 weeks, and if that is well tolerated, we increase to the max dose of 1 milligram sub-Q weekly. Next, we have dulaglutide. This one may be more challenging because each pen only contains 1 dose, so it may be hard to just give the patient 1 pen of each dose. So what I do is I just allow the patient to finish the supply of whatever dose they have and then up titrate to the next dose if it's well tolerated. How we can do it, the most rapid way would be 0.75 milligrams sub-Q weekly for 1 week. Then if that's well tolerated, you can increase to 1.5 milligrams sub-Q weekly for a week. If that's well tolerated, you can increase to 3 milligrams sub-Q weekly for a week. And then if that's well tolerated, you can increase to the max dose of 4.5 milligrams sub-Q weekly. SGLT2 inhibitors are great medications for diabetes, especially for patients with cardiovascular and renal comorbidities. They cause the kidneys to excrete sugar when the sugar is high, and they do not cause hypoglycemia. The most common side effect we see with SGLT2 inhibitors is volume depletion. Patients should be counseled to drink enough water on these medications. There are potential significant adverse effects associated with SGLT2 inhibitors. It is important to inform your patient of these and to be aware of them when you are treating patients using these medications. It is important to screen patients for frequent UTIs and yeast infections prior to starting these medications because they are not a great medication for patients who have these issues. It is also important to screen patients after they've been started, and if a patient develops UTIs and/or yeast infections while on SGLT2 inhibitors, we typically discontinue them. Rare adverse events associated with SGLT2 inhibitors are euglycemic DKA, which we do see clinically, however rarely, and Fournier's gangrene and an increased rate of amputations were seen with canagliflozin. There are some other medications that can be used for diabetes in specific populations. We try not to use SUs and TZDs that often anymore due to side effects and adverse effects. They may be used when cost is a major limitation. Glinides and DPP-4 inhibitors have limited blood glucose lowering efficacy, thus are reserved for specific populations.